Yeah, good evening, everyone. You start with a sneeze. She. Good
No,
evening,
no.
everyone.
Are we live?
Yes, good evening,
Okay.
everyone. So today's topic is on the symptomatic, the presence of how endometriosis or an adenomyosis patient will come. And many a times there is so much of confusion among the symptoms. So there is extremes where any pain, now they think of endometriosis. So I met a couple of my colleagues in a recent conference and they told me that so much you people are talking about endometriosis. Even if a patient comes with headache, we are thinking of endometriosis. And then there is another spectrum where there are no symptoms, but when you put in a scope or even when you do a scan, there is like full blown grade 4 endometriosis. But here today's topic is like what is the problem or what is the pathophysiology which is causing the back pain and also the pelvic pain in a case of endometriosis. So this is the, I think, one of the most common symptom anybody will present with endometriosis of any age group, be it fertility, post fertility, like after 40s, or even youngsters like adolescents who are now getting diagnosed more and more with endometriosis. So I think we should know as to why they have this the significant symptom which can really affect their quality of life. So when we are talking about quality of life, I think that is where our management also, like, makes us take some important steps and some decisions which are important. So Dr. Jay will tell us about the reasons for the pain so that our evaluation can become a little better based on the symptoms.
So, two or three things are important when we try to talk of pain in the pelvis or pain due to endometriosis or pain due to anything, right? Just keep one thing in mind. Any pain is going to get a patient to the doctor, right? For sure. It is our responsibility to make sure if we are evaluating chronic pelvic pain, that is persistent nagging pain in the pelvis, at least with a window of 4 to 6 months. So that means it has been going on for 4 to 6 months in absence of any known cause in the pelvis, right? The most important word here is in absence of any known cause in the pelvis. And the first differential there is endometriosis and adenomyosis, right? Many times what we label to be a normal pelvis, we see this very often because, as madam said, we end up consulting a lot of patients who are having chronic pelvic pain. We will call them to Bombay to get evaluated for ultrasound. Once we call them, and Aarti madam knows this because we recently had somebody like that whom we had called to Bombay in her Hyderabad OPD, and madam also evaluated the same patient. Okay. And remember, when somebody is told chronic pelvic pain, when your evaluation is good, the possibility that you will end up picking up endometriosis is very good and very high. Both the things. Okay. So this is one thing which you have to keep in mind. That is the first thing. I am going to correlate why pain occurs with why sometimes medical management does not work in pain. See, we all know this as a global rule. If you are a patient listening to this, 100% you will correlate to this. You went to a doctor, you were diagnosed with endometriosis. 98% of our colleagues are going to put you on some form of temporary pain management, right? And some of you would have messaged to our team stating that we are not experiencing any pain relief out of that. So this is a class which will teach both patients as well as medical practitioners why sometimes there is no pain relief. And in order for you to understand that, you need to understand why pain happens in endometriosis, right? So I'll be drawing something. I am not going to be drawing the normal thing which we expect, that because there are so many adhesions, there is going to be pain. That's probably not true. Am I this thing? Is the screen visible,
Yeah.
Aarti ma'am, Shilpa ma'am?
Yeah. Yeah.
Okay. So I'll just erase all of this and I'll try to draw pelvis into two parts. Okay. So part number one is urethral meatus. You have the bladder, you have the vagina, the uterus, which is probably retroverted above that. And you have the bowel, which has come and got adherent here because of endometriosis. That is part number one. Part number 2, I'm going to draw a cut section of the bladder. This is the cut section of the bladder. Detrusor muscle is here. Behind the bladder, we have the cervix, small cervical canal. Behind that, somewhere you have the rectum, empty rectum. And now it is important to understand that from here, you are going to have uterosacral in the coronal plane. Besides the uterosacral will be going, or rather I would just say underneath the uterosacral, you will have the presence of hypogastric nerves, which will be then going supplying the uterus, supplying the bladder through the plexus on both the sides. Correct? And in the body, in the human body above that, I just draw a small face. Kindly accept my drawings as they are. Okay. Whatever leg. Fine. Some of them will have hands also. And you have your stomach muscles, which is your abdominal muscles predominantly. And you have the lateral muscles here, right? This much we all know. Now, remember what some theories try to correlate with the pain, and this is going to be very, very quick. Okay. Point number 1. Sometimes you have these dense adhesions, rectal adhesions, vaginal adhesions, cervical adhesions, and what typically happens is when any one of these organ moves, okay, ideally these organs are independent of each other. But when these organs are stuck, there is something called, which Aarti madam and Mamta madam normally teach us, there is something called as absent sliding side. That means these guys are not sliding against each other. They are stuck to each other, like how people are stuck in a Mumbai local train, you know, densely packed, no movement. One person moves, 5 people will move along with that, and that movement is going to cause pain. That is because these organs are not used to such atypical movements. But the actual reason is here. These are your pain carrying sensations. Some of them are going to be carried through the hypogastric plexus. And when some of the pain sensations are carried through the hypogastric plexus, it is the hypogastric plexus which also gets adherent. See, the adhesion is somewhere here only. So these nerves are also getting adherent. Because these nerves are getting adherent, there is pain. So that is one of the reasons why there is so much pain in endometriosis. Second is something which happens very commonly in endometriosis, and that is something called as sensitization. See, over a prolonged period of time, by the time a patient reaches a doctor, sensitization of endometriosis would have usually taken place for around 1 year. That's when they will go for an ultrasound. Haan, theek hai, little pain here, there. They will take Meftal, they will take cyclopam. Pain is not going down. Somebody will drag them to a doctor. Okay, then they will understand, oh, I am having endometriosis. By this time, what has happened is chronic pain sensation, which is originating close to this nodule, has hypersensitized the pain signal going through the nerve, going through the back, and finally into the brain. So any sensation coming from the pelvis is going to be hyper exaggerated, and that gives rise to a lot of pain. For example, we often talk about this. You have a small peritoneal deposit here on diagnostic laparoscopy at the UV fold. Okay, sometimes you will see a small peritoneal deposit on the lateral pelvic wall, and sometimes that is the only endometriotic deposit which you have, isn't it? And then the patient is saying, "Ore, I am having so much pain, I am having so much pain, I am having so much pain." That is predominantly due to sensitization. Prolonged stay of that region over that peritoneum hypersensitizes the nerves there. So whenever a new small lesion also comes up, okay, there is too much pain inside the pelvis, and that is the theory of sensitization, very commonly seen. As a result of this, many a times people who are listening to this will agree that when you treat chronic pelvic pain and when you do something called as diagnostic laparoscopy, we often advise this. We were recently discussing with Aarti madam, one patient had irritated the shit out of her from United States. Okay, imagine somebody irritating the shit out of Aarti madam. Matlab, that person really has to be the scoundrel of the highest order, isn't it? They called up Aarti madam and they submitted some 60-70 page report that this is there, that is there, what should we do, shall we do diagnostic laparoscopy or not? Majority of the times, for people who trouble other people like this, when you do a diagnostic laparoscopy, you will agree that either in a country like India, you will find this thing called as chronic PID, or in India, you are going to find something called as peritoneal endometriosis. Okay. Now, this peritoneal endometriosis is otherwise very, you will classify it as grade 1 ASRM classification. And then you will say, Arey, grade 1 is mild to moderate endometriosis. You don't have to do much about it. That is correct. You don't have to do much about it when you are in America, because it is American classification. But if the patient is in pain, you have to treat the pain. The minute you do peritonectomy in these patients, majority of them are going to be grossly relieved of their pain. Okay, that is something which you have to understand. And this is what makes you understand, or figure out that sometimes when you are having chronic pelvic pain, people have experimented giving Dynogest. Acha, I am not able to find anything. I love Dynogest any which ways. You take Dynogest. Understanding, and the patient is very happy for 3 months, 6 months. That is because that small dose of Dynogest has gone, and it has reduced the size of the nodule, which has in turn reduced the sensitization of the nerve, and patient has experienced pain relief out of that. But everything bounces back once Dynogest is stopped, isn't it? And this gives you some clue that, okay, there could be some endometriosis somewhere which has been missed out on, right? Apart from these two things, please try and understand what also plays a very important role, especially is the hormones. So you have estrogen, beta receptors, which are predominant, they end up secreting a huge amount of cytokines. These are the cytokines which then end up secreting a large amount of PGE2. And this guy PGE2 goes and causes hypercontractility of the uterus. Apart from causing hypercontractility of the uterus, it also adds to pain, because PGE2 is predominantly used for uterine contractility only, as far as obstetrics is also concerned, right? We use PGE1 and PGE2 gel when it comes to delivering patients. So in that situation also, this excessive PGE2 causes uterine contractility. Uterus goes into spasm, and because uterus goes into spasm, a lot of women experience spasmodic pain. All right. Finally, you must remember endometriosis is many times associated with this disease, and this disease inside the uterus is called as adenomyosis. Adenomyosis goes and directly affects the uterine musculature, and because it increases something called as wall thickness, we always end up measuring adenomyosis as anterior wall thickness versus posterior wall thickness. And because it adds a lot to the bulk of the posterior wall, it gives rise to a tremendous amount of pain. Now remember the logic which comes behind this. See, whenever you have any muscular growth, okay, even if you give medical management may or may not work, because medical management is optimized for a standard size of the muscle, right? Now, if the uterus, because of adenomyosis, has become, let's say, 12 centimeter, the normal medical management is acceptable for an 8 centimeter uterus. If you are trying to experiment with somebody who is 12 centimeter uterus, you can't expect the same Dynogest to go and work there. Simultaneously, you can't expect the same Luprite depot to go and work there. Elagolix ka to bhul hi jao. It is not even in the picture when these two people are not working. And that is the reason why you have size criteria for treatment of disease. Okay, bhaiya, if adenomyosis is more than 10 centimeters in size, medical management is going to rarely work. And that is the reason when adenomyosis is more than 10 centimeters length of uterus, you end up taking surgical managements, because patient has to offer and patient has to get done this word. See this? Debulking, isn't it? Only when debulking happens, the mass effect of the disease goes down and patients start feeling better, right? Sometimes I drew this particular lady with her muscles like this is because of this chronic pain which is occurring in the pelvis. There is a hyperstimulatory response which occurs to the abs. That means to your rectus abdominis muscle. And this rectus abdominis muscle, beyond a point in time, stops responding the way it should be responding. And as a result of this, it gives rise to hypertonicity of the lateral abdominal wall muscles. And that is the reason for predominantly having back pain. Here I will answer one question. The first question which people are going to ask you when they get operated is, doctor, how much is going to be my pain relief? And if the patient is having only pelvic pain, remember the pain relief is going to be in the tune of more than 90%. But if the patient is complaining to your vague symptoms, I have pain in the leg, I have pain in the upper abdomen, I have pain in the back, I have pain here, I have pain there, then remember these are offshoots of chronic pelvic pain. Chronic pelvic pain will take its own sweet time to settle, even if your surgical completion is achieved. I repeat, even if the surgical completion is achieved, people will come and tell you, my pelvis is very good, but my left thigh is still paining. My pelvis is very good, but my right side back is still paining. Understanding? Commonly, as doctors, we would also like to evaluate that, okay, is there any spinal issue? Many times, because people have been pumped with Lupride and all these things, there is osteoporosis. And this osteoporosis also causes back pain to the patient. But our counseling to the patient, as far as back pain, as far as vague abdominal pain, has to be that once surgical completion is achieved, it may take some time for that pain to go away. Okay. We don't know how much time, but the typical time is usually 3 to 6 months. In that 3 to 6 months, if the patient is experiencing pain, what should you do? The best medication which you can give is basically calming down the central nervous system. That is why you will see that in chronic pelvic pain, drugs like anxiolytics, Librax, works beautifully because it is a serotonin receptor antagonist. It reduces the number of serotonin dopamine release in the brain. It calms down that pathway. Simultaneously, something which is very good in the market, which we have tried a lot. I think Aarti madam has also started trying it. Shilpa madam has also started trying it, is giving these patients Unecta. Unecta is basically a drug which is a melatonin agonist. It induces very good sleep. Okay. What it does is it is not addictive. It allows the people to sleep for 8 hours. If they are sleeping, it gives them around 20% deep sleep. And remember, this deep sleep is very good, very important to reduce the sensitization of the pain pathways. Okay. When you reduce the sensitization of the pain pathway by giving such type of basic drugs, most of these patients who have been on chronic pain end up settling down in 2 to 3 months. This is one condition where, because of this vague expression of pain, because of chronic endometriosis, okay, people will do well with acupuncture, people will do well with yoga, people will do well with meditation. All these things will help these patients in the post-operative period. As a result of this, it is very important that when you try to do a pain score of the patient pre-surgery, you should know which pain score you will be addressing. You will address dysmenorrhea, you will address dyspareunia, you will address dyschezia, you will address deep pelvic pain, you will address pelvic pain which occurs while passage of stools, pelvic pain occurs while passage of urine. But if the patient is also complaining of vague symptoms, as I told you, sir, I have some pain in the back somewhere, I don't know where, they will not be able to localize it. All the other symptoms which I mentioned are localizable symptoms. They will tell you, sir, some pain happens in the thighs when I'm walking. Arey, wo to mere ko bhi hota hai, right? We will always try to think like that. Those symptoms of pain which you can't localize are not the symptoms based on which you will have to measure your pain score in endometriosis. If you end up measuring your pain score in endometriosis based on non-localized symptoms, this is not true when you have extrapelvic endometriosis. For example, when somebody has abdominal wall endometriosis, she'll tell you my pain is in the abdomen here only, take. If somebody has inguinal endometriosis, she'll point in the inguinal. Episiotomy or perineal endometriosis, she'll point in the perineum. Diaphragmatic endometriosis, she'll not point anywhere. She will tell you, I have something. Understanding? But the pain relief is 100%. So you have to remember these small things. Non-localizable pain, no matter how good, how bad it is, usually, even after your surgery is complete, you will require alternative approaches and long-term follow-up to keep your patient satisfied. And that is a very important counseling point. Non-localized pain, no medical management will work because your pain is non-localized. That means it is predominantly happening due to CNS. CNS does not carry estrogen receptors. If you have localized pain, estrogen receptors are present. Give Dynogest, that is where it will help in temporary pain relief. Give elagolics, that is where it will help in temporary pain relief. By temporary, I mean to say 3 to 6 months, not 3 to 6 years. Okay. With this, I conclude. I thought I wanted to correlate pain with all its symptoms and all the pathways in endometriosis. And I'll be happy to answer some questions now.
So, pain, as you know, I mean, we deal with this every day with regard to when we are treating with so many cases of endometriosis. So, the patient just want pain relief. In
Yeah.
at least like 30-40% of them, we see that their primary thing, I mean, forget about fertility, forget about anything, they want just the pain relief. So, irrespective of like, surgery, medical management, whatever it is. So, we're coming to surgery, when you operate on deep endometriosis, especially grade 4 endometriosis, so what is it that you counsel when it comes to the pain relief? I mean, do you tell them that 100% the pain relief will be there, or
99. The reason why I'm telling this is because any localized pain will get relieved, madam. Any localized pain. If she is telling you I'm having deep dyspareunia, 100% there is a uterosacral nodule somewhere. If you remove that nodule completely, pain relief is given, absolutely given. But as I told you, if she is telling some pain right thigh, okay, very tough. Even after you operate, very tough. Because no matter what, we have seen it, right? We had operated one young girl, remember? She was absolutely fine for approximately 1 year. After that 1 year, again, she started having pain. I mean, for that 1 year, we did nothing special, but there was no pain. After that 1 year, the pain sensitization would have changed, and she is probably now localizing the pain somewhere else, which is why now she may go to some other doctor thinking my knee is paining, my thigh is paining, my back is paining, whatever.
So, in your experience, when you operate so many bowel endometriosis, so many lateral pelvic wall endometriosis, and like you showed the obturator nerve endometriosis, in such cases, when it is like, long standing disease, and when it has been missed for a very long time and nobody would have suggested to do the surgery. So once you do the surgery, still like 2 to 3% of them will come back with that lingering pain. Do you think they're paranoid because like they're used to having that pain, any little pain which happens, I mean they attribute it to the disease? I mean today I saw one
Uh,
of our patients.
one is that, madam, as you said, any little trigger thing which even if they fight with their husband, they will think it is due to endometriosis. Understanding? That is called that triggering. Any trigger factor will localize the pain to the pelvis. That is how the CNS works. Okay. But if you remove these nodules, I mean, I showed obturator nerve endometriosis yesterday. That patient is still in my hospital. Okay. You will not believe, she is a patient whom I had actually seen in Aarti Madam's hospital. Okay. With severe endometriosis. Like we had seen her in the hospital, and both me and Aarti Madam had told her. In fact, myself and Aarti Madam were sort of fighting with each other. I told that why we will operate it in your hospital. That's what I was trying to tell Aarti Madam. And Madam was like, it's too big. You may have to do it in Bombay. Right. Of course, both of us didn't know that it's going to be obturator nerve involvement of endometriosis. They are from a place, I think, I don't know, I don't even know if it is a remote place or not, but the name, I know this very clearly because today I have spoken right to the MLA of that place for this particular girl. Okay. And the name of the place is Shrikakulam. All right. And that is located in Andhra Pradesh somewhere. All right. Now, this girl is a teacher. The husband is an IT professional. She goes to some school where she is at a good position, so she knows a lot of people. The first thing which she told me today morning was that I have no pain when I'm moving my legs. And I was like, why did you not tell us about this before the surgery happened? Right? And she was like, no, before the surgery happened, no, I was in extremely severe pelvic pain. So this got cancelled out. I did not know that this pain is also existed. This pain relief, no, of localized pain. See, had she had only obturator, she would have told, I am not able to move my legs properly, whatever. She would have told us something. Correct? She was not able to tell us. But today morning, she told me that God knows what you did, but whatever you did, my pain is not there when I'm moving my legs. I'm able to move my legs freely. I'm able to walk nicely. I feel light in the pelvis. This is the first thing which majority of girls will tell you if you have operated a localized pain. And as counseling points, because you asked that counseling point, and because you mentioned that somebody whom you saw today who must have come back with the same vague pain somewhere, understanding, if it is a pre-surgical vague pain, high possibility it will continue to be a post-surgical vague pain at some different location. But if it is a pre-surgical localized pain, the pain relief which you will offer to the patient with surgery is mind-blowing.
Also, I see that like, sorry, I will just
No,
finish this. So if there is a lot of pain, see, we see at least 25% of them who come with like severe pain, which is like, their quality of life, it's
gone.
really
Yeah.
gone. And they say that they can't concentrate on anything, they have taken off from work and all this. And in such cases, we invariably see that there is a lot of nodularity. not just in the parametrium. It could be like, peritoneal deposits. It could be like how you told, like, hyperactivity of the peritoneum, and also over the nerves, encasing the nerves, and also it is quite diffuse, and you just need to be a very good surgeon to actually, like, dissect it out and do the complete clearance. So whenever there is severe pain which is really affecting the quality of life, and if they have either, like, solitary endometriotic cyst or like bilateral endometriotic cyst, it is always wise to think about the endometriosis being in, like, in the lateral pelvic wall, also in retroperitoneal area too. What do you think of that?
I think in one of the classes we discussed this. If there is a bilateral ovarian cyst, possibility of having deep endometriosis is close to 95%. If there
Yeah.
is a unilateral ovarian cyst, possibility of having deep endometriosis is close to 55-60%.
Yeah.
But if the patient has a palpable nodule more towards one of the lateral walls, okay, that means the possibility of parametrial endometriosis is pretty huge. And people often don't understand this. You know, just because people like to sound cute, they like to use the words that, you should operate only a particular part when it is absolutely mandatory. And many a times you are not even going to understand if operating there is mandatory or not till you open that part and see, right? This has happened so many times across all our locations, so many times, isn't it? So I personally think the target should be very simple. Restore the anatomy back to how a normal pelvic anatomy would be. When you try to restore the anatomy back to normal, majority of the stuff gets taken care of. Majority, right? The only place where things are not taken care of is in the extreme lateral pelvic wall. And extreme lateral pelvic wall, the first thing which should strike you, okay, is medialization of the external iliac vessels. If they have been medialized, external iliac vessels, that means there is something deep down there which you have to figure out and which you have to resect. Okay, that is a take home point, but that's a surgical take home point. It's not got nothing much to do with the pain, but that is something which you have to figure out and operate. You can't look at it and say, oh, it was so cute. You can't do that.
Yeah, thank you very much. Aarti, any questions you have?
Yeah, I just have a couple of them, Jay. Very lovely take-home clinical points, Jay. Really loved them, especially, the localized pain and the non-localized pain point which you discussed, that if the patient is having localized pain post-surgery, they will benefit and give you a good pain relief, good outcome. And when they're not having localized pain, they continue to have these vague pains for 3 to 6 months, is what you mentioned.
Yeah.
Now, I've seen a few patients post-operatively complaining of this radiating pain in the leg and numbness.
Yeah.
So, your comments on this?
Numbness and radiating pain both will happen when you have done exposure and dissection of any nervous tissue. For example, obturator nerve, genitofemoral nerve, sciatic nerve, pudendal nerve, whatever. Okay. If you go too lateral, what will happen is the fascia covering these nerves and the nerve roots, especially when we are doing such, lateral pelvic wall dissections and all these things, they tend to get exposed. And when they are in their healing phase, see, sometimes the neural covering over that gets damaged. In that healing, it causes this shooting type of pain, which can occur to only one leg. See, we have dissected on both the sides, but pain will be only on one leg. We have dissected something, pain will be somewhere else. All these things are common. And that is related to neuropraxia, basically, some type of nervous system repair mechanism. And that will normally take 4 to 6 weeks for them to heal. Does not require pregabalin, does not require anything.
So what do you give for these patients who present to you with these non-localized pains before surgery, and you know that they're not going to have a great pain relief post-op?
I like to give them Unecta and OCPs both. So Unecta, we have
What is
only
the spelling of that Unecta?
EUNYCTA.
Okay.
Yeah. And I also like to give them oral contraceptive pills, because just in case there is some endometriosis somewhere, no, it will get relieved on that.
Okay. And do you see a difference in the signature of the pain a patient may face with different types of, pelvic endometriosis?
See, the commonest pain by the time they come to us for surgery, it is already deep endometriosis, madam. So the commonest pain for the patient is going to be either dysmenorrhea or it is going to be pelvic pain. They can't localize. They can't tell you it is dyschezia. They can't tell you it is this. But remember one thing, a lot of them will have probe tenderness, madam. When your ultrasound probe touches the nodule, they will wince in pain. When the ultrasound nodule, when you try to do a sliding sign, which is negative, in that act of sliding, they will have pain, madam. And that gives you a crystal clear indication that because she is wincing in pain on this, the minute I operate her, she is going to be super happy,
Right. And we see two extremes of patients, Jay. One extreme is the patient is complaining of severe pain. That's why they've come to you, but a pelvic scan is absolutely clean. And then the other extreme is I'm seeing very often these days patients just going for a routine gynec checkup and they are having grade 4 endometriosis, large endometriotic cysts, uterosacral nodules, and they are not even complaining of pain, and they're so surprised and they're not able to accept the fact that they require a surgery.
Actually, the next two lines which I mentioned is going to be very good lines. When patient is coming to you with grade 4 endometriosis and is telling you I am asymptomatic, that is the patient whom you need to operate the first. Not like how we typically think, you are asymptomatic. I'll not even give you Dynogest. Wrong. If the patient is asymptomatic, that means the nodule has given rise to something called as nerve damage in the nodule. That means there could have been episodes of multiple hemorrhage with fibrosis inside, where even the nerve roots have undergone fibrosis and they are unable to carry signal back to the CNS, central nervous system. That means the amount of puckering inside is going to be very severe. This means that this patient has had long-standing disease, typically more than 2 to 3 years, and it is at a stage where it may cause some amount of constriction, deviation, pain, and because it is not causing pain, you have grossly misjudged the severity of that, right? As a result of this, the first patient whom you should operate is an asymptomatic patient. Because that is a lady who is unable to even tell you how severely affected she is. Correct? The minute you give them the best explanation to this is ask them, get out of my consulting room and just type asymptomatic endometriosis on Perplexity AI. What an answer it gives. Believe me. That is the same line it tells. Just because you have asymptomatic endometriosis does not mean that your disease is in control. In fact, this requires further evaluation and high possibility that you may have extensive disease. Okay. And which is why asymptomatic endometriosis, which we see, let them not immediately see. Some people are destined to suffer. So you can't really counsel everybody. Correct. But these are women whom we should give priority as medical practitioners and take them up for surgery the first.
Superb. So basically, how when a UPT is positive and you have a PUL, a pregnancy of unknown location, we think ectopic. If a patient is having chronic pelvic pain, we should think endometriosis.
We should at least rule it out.
Okay. So thank you. I think I'm done with my questions.
Thank you very much. Thank you everyone for